Yes, we can hear you.
Yes, we can.
Okay, thanks. Okay, so welcome everybody. In this, the first teaching for surgical gastroenterology fellows on the GECKO platform. So GECKO is the gastroenterology and hepatology echo of the Gastro Foundation, and it's being run in association with Project ECHO of the University of New Mexico. So this meeting will run every Monday at 16:30. The topics will rotate between HPB, upper GI, and colorectal. That I think is a good thing, because I think there are very few, regardless of which interest you choose in your training in surgical gastroenterology, people that only do what they train for. In any case, Marc Bernon is going to host the first one. Next week it will be Adam Bootle, and we'll come back to the topic later, and after that Galia Chinnery. But the faculty that you will see that eventually is going to be involved in the sessions are from all the faculties in South Africa, and in some cases even from other countries in sub-Saharan Africa. So this first three is really a trial run that we going to do it in a format that we think is relevant in terms of preparing for the exams. As you know, the exams now are case-based, and also just for the practical management of patients. And then after the first three, when we've really sort of honed the session a little bit, it will be open for other fellows in sub-Saharan Africa as well, but the format will stay the same. So please comment on the format. You can make your comments in the chat. This is interactive, and Marc will explain to you how he's going to do it. So it's really we want people to participate and make it as interactive as possible. All right, Marc, over to you then. Thanks.
Thanks, Ed. I'm just going to share my screen. Sorry, let me just go back. Can you see that?
Yes.
Okay, great. So I chatted to our fellows, and there's three of our fellows who are going to be involved in this. So it's Yalda Ziai, Wanga Ntunkulu, and Sanju Subnach. And they didn't really want me to give a didactic lecture because we've had so many talks about hepatocellular carcinoma. So I was thinking about it, and I think when you're studying for an exam, and this is geared towards preparing you for the exam, for most cancers, you can sort of divide what you need to know into the topics that I've listed here. But because the exam is case-based, you need to be able to apply this practically. So I'm going to start with the first case, and I did give these cases to our fellows about an hour ago, so they've had some time to go through it. So the first patient is a 67-year-old male who presented with a life-threatening variceal bleed at another hospital, was transferred through with a Senstarken Blakemore tube in situ. Previous to this bleed, he was not known to have liver disease. He had a fairly significant ethanol history, was overweight, not obese, but overweight. On arrival, he had a high ammonia, was encephalopathic, he had ascites, his MELD score was 19, Child-Pugh score of 11, so he was a B, and these are his blood results. His alpha-fetoprotein at that stage was 10.2. It's just worth noting that these bloods were done at the time of a bleed. So, Yalda, the first question I had for you is, how would you manage this patient in hospital and then once he's discharged? And just what are your thoughts generally?
So generally, any patients who's coming with an acute
Yalda,
bleed.
can you just share your screen as well?
Yeah, just put your camera on, Yelda.
Sure. So basically, any patients coming with a bleeding, we're gonna start with the ABC and the proper resuscitation of the patient. You said that the patient already had a sanguine tube in. So I will start with the resuscitating hemoglobin is 6.9. Starting asking for a blood transfusion. Before the blood comes, we can start with the crystalloid IV infusion. The patient's octreotide infusions give the patient a broad spectrum antibiotic. And the INR was 1.6. We generally like the INR to be 1.5, so maybe 1 unit of FFP as well to order for the patient. Once everything is ready, then I'm going to take the patient to the theater under control environment. We're going to try to do a G-scope for the patient and identify the source of the bleeding, and if it's possible, control the bleeding. If not, then we can put another temporary measure like a sanguine tube or even dialysis stent, and bring the patient in like 48 hours later to reband the patient and try to do that. Monitor hemoglobin in the ward, serial hemoglobin, and once the patient is clinically, once the banding is applied, the patient is clinically stable, no more bleeding, we can stop the octreotide infusion and start the patient on propranolol. Now, at the same time, we need to start investigating the patient for the cause of the variceal bleed. We can check the hepatitis profile of the patient, HIV status. I can see that the alpha-fetoprotein was done already for the patient. If there was no CT scan, we can do a CT to identify the causes of the portal hypertension. If there is any ascites, we like to tap the ascites and send it for culture. And another investigation, yeah.
Yeah, so I think that covers it pretty well. So your initial management was good. The timing of doing the repeat endoscopy, I think, depends on on how unstable the patient is and if the Senstarken tube is working. So I think, if it's working well and the patient is a little bit unstable, you could resuscitate the patient and get them into a slightly better physiological state. But I do think it's quite nice to get the Senstarken out. If you can band the varices, that's great. And if you can't control the bleeding, a Danner stent, I think, is nice because you don't have this tube coming out the mouth. You could potentially extubate the patient with a Danner stent in situ. So you mentioned the hepatitis B and hepatitis C. Are there any other investigations that are sort of routine when you're working up someone for cirrhosis? So this patient does have a strong ethanol history.
Yeah. So we can also check for.
Once he was a bit better, he told me that he'd been told in the past that he had high iron levels. Mm-hmm. So I checked his ferritin, but it was low, and that was obviously because he'd recently had a bleed. So what else could you do? What other tests could you do to see if there's a problem with his iron metabolism?
The ferritin.
So we did the ferritin. So that the other test that you can do is a HFE genetics, looking for some of the abnormalities that you get with hemochromatosis, and he was heterozygous for that. So he doesn't have hemochromatosis, but he had high iron stores, plus he probably had an element of metabolic associated fatty liver disease, plus he drank, and that puts him at quite high risk for developing hepatocellular carcinoma. So we routinely do a CT scan, as you know. Let me just go back to it. Where is it now? Sorry, I don't think I have it here. Oh, there it is. We routinely do a CT scan for these patients. What are you looking for in the CT?
We're looking for any cirrhosis, any nodularity of the surface, any portal vein thrombosis, any lesions in the liver, if there is any ascites.
So what did you think of his CT scan?
So when I looked at the CT, I can see that the left, there is some nodularities or irregular surface of the liver, suggestive of cirrhosis. And then the left lobe is quite hypertrophied comparing to the right side. Some ascites is there, but not much. And small thrombus in the main portal vein, but it's not including the vein itself.
Yeah. So I think you picked up the relative findings. So the reason that we do it is, to look at the liver anatomy. And in this case, the liver does look cirrhotic for the reasons that you mentioned. I think it's quite important to see if the portal vein is patent or not, because that helps you decide whether TIPS is a potential salvage option in the patient. And then the other big thing is to rule out a hepatocellular carcinoma. Hepatocellular carcinoma often invades into the portal vein, and that bumps up your portal pressure. And one of the ways that patients present with an HCC is with a variceal bleed. Ultrasound is not that good at picking that up in our situation, and that's partly because ultrasound is so user dependent. So I feel that when you present with your first variceal bleed, that you should have a CT scan. All right, so now I did mention that I'm going to go back. Let me see. So when he gets discharged, what should his management be?
So on discharge, we need to make sure patient is on beta blocker and diuretics. We need to involve the liver team, just a liver follow-up, and the patient should have a regular follow-up to come for the variceal banding and surveillance.
Okay, so he needs to have his varices eradicated. So secondary prophylaxis, we refer to secondary prophylaxis. So that is non-selective beta blocker like propranolol or carvedilol, and regular endoscopy until the varices are eradicated. He should be on diuretics, as you mentioned. And there's something else that needs to happen.
We need to monitor.
He's got cirrhosis.
Cirrhosis, he needs to be on the surveillance for any HCC.
Yeah, so the whole thing about surveillance is if you're in a surveillance program, then you are more likely to be picked up with an early stage HCC, where we can actually offer some sort of curative intended treatment. If you get picked up with an intermediate or advanced stage, then there's often nothing that can be done. And we know that in sub-Saharan Africa, 72% of patients are picked up with stage D disease. Only like 5% are picked up with early disease where we can offer some form of treatment. And the only way we're going to really be able to change that is by putting all of these patients into a surveillance program. All right, so, and the surveillance is basically an ultrasound and the alpha-fetoprotein 6 monthly. And then if you pick something up on the ultrasound, or if the alpha-fetoprotein is rising, then you need to do some form of cross-sectional imaging. Okay, so moving on, he actually improved quite remarkably. So this whole thing happened, I think it was at the end of 2020. And then he came for a number of scopes to eradicate the varices. His blood results, his blood's improved, his liver function improved, the ascites is resolved. His MELD score actually improved to 9, and his Child-Pugh score became 6. But his alpha-fetoprotein increased to 112. The ultrasound didn't show anything. So we went on to do a CT scan. And at the time of the CT scan, his alpha-fetoprotein had increased to 4,200. What did you, I'm going to show the scans, but maybe while we're talking, what did you see on the CT scans? So this is the arterial phase.
So on the arterial phase, I could see that there is some increase in the vasculature, especially in segment 3/segment 2 area. But it was more clear. The lesion, actually, it was more clear for me when I looked at the portovenous phase.
Yeah.
that there was a hypodense.
So I think sort of in that vicinity there, is that what you're talking about?
Yes.
Yeah. Okay, so like you said, I'm going to go to the portal venous phase because you do see it better there.
And the other thing I noticed in the portovenous phase that the thrombus was slightly increasing in size, but still it was not completely occluding the portal vein.
Yeah. So there's a lesion and it's not very well seen in this vicinity over here. Can you see it there?
Mm-hmm.
So that is really the only lesion that can be seen on the scan. So in view of the alpha fetoprotein being 6,200, what are your thoughts? Is this
So I think,
diagnostic of? Oh wait, sorry, that
I
was.
think with
Wait. Sorry, I think I was showing the wrong. There. You can see it better. That's the portal venous phase. Sorry.
I think in this context, with the history of the patient and the liver cirrhosis with the high alpha fetoprotein, and we can see that there is a washout of the contrast in the portovenous phase. I would think that this lesion is most probably HCC.
Okay. So you can see how it's quite. This is the umbilical portion of the left portal vein. It's quite closely related to it. The radiologist felt that there was tumor in some of the smaller branches of the portal vein on the left side. So it doesn't have enhancement on the arterial phase, but I think with tumor in a vein and an alpha fetoprotein of 6,500, that is sufficient to make the diagnosis of hepatocellular carcinoma, and a biopsy is not really indicated. So what are the management options for this guy?
So if you
So I'm
look
going to
at
show,
the,
so just while you just discuss it, I'm just going to put the Barcelona Liver Clinic staging system up there, but I think it's not always as clear cut as you know this suggests. So we can just chat about what the options are.
so I wasn't quite sure about the size of the tumor. I couldn't measure it in the video, but I think just looking at it, roughly it was more than 3 centimeters.
It's about 3.5 centimeters on the portal
Yeah.
venous phase.
So that's basically, it's not going to classify the patient into very early or the early stages. I would think maybe resection versus tasing of the patient as probably
So-
downstaging or bridging, downstaging to see if the patient's going to be a candidate for liver transplant in future.
So what do you think about the alpha fetoprotein? Does that affect your, I know it doesn't come into the Barcelona Liver Clinic staging system, but how does
Yeah, it
that
doesn't.
play into your
So,
thinking?
So with the high alpha fetoprotein, it means either the tumor is very aggressive or high tumor burden. So the patient usually, for the transplant, they like the alpha fetoprotein to be less than 500. So that's why I think if we try with the TACE for the patients and we monitor the alpha fetoprotein, if there is decrease in the number, maybe the patient will be a candidate for a transplant.
You mentioned resection. Is portal hypertension a contraindication to resection?
It can make the surgery more difficult, but increases the risk of bleeding.
Yeah, so I think it depends on how big the resection is. I think it's a relative contraindication, but if it's going to be a small resection, it's potentially possible. So our feeling was that in this case, with such a high alpha fetoprotein, that and the patient had some the patient was a bit overweight and it had portal hypertension, that we didn't want to rush into surgery, so we did a TACE, and I was pleasantly surprised by the TACE because the alpha fetoprotein dropped precipitously afterwards, and within about 2 weeks, it had dropped to about 2,000. And within about 2 months, it had dropped down to 30. So we rescanned the patient, and the lesion would look much the same on the repeat scan. So we did another TACE about 2 weeks ago. So considering that now, and thinking about what the image looked like, what would you consider? What are the options? Because there's more than one option. And what are the advantages of the different options? So there's like we could retaste, keep on retasting and not operate on him, but that's a pattern that would not result in a long-term cure. You could resect him, but there is a risk associated with that, but it's not going to be the biggest liver resection. And you could argue now that he falls within transplant criteria, and you could transplant him. So all three of those options are potentially on the cards. He wants to be cured, so that my feeling is a good middle ground option for him is a liver resection. So I don't know if anyone has any comments. I think we're coming to the end of this first case. Ed, I don't know if you have anything to say, if Sanju or Wanga or anyone else have any comments.
Mark, no, I don't have anything specifically. If there are any other fellows that have got a question.
Mark, it's Sanjay here. I just wanted a question. So I just have one question. You often downstage these patients and you go down to a very low alpha fetoprotein, say below 400, you're quite happy they're going to be transplantable. 6 weeks later, you do the alpha fetoprotein, and here it is, it goes back to about 400. And you know, if you read any of the guidelines, you can't really find out when are you supposed to repeat the alpha fetoprotein. What is our policy here? Do you do every like 6 months, every 3 months?
So his alpha fetoprotein went up very quickly. My experience with this is that once you've treated it, like with a TACE or whatever, if it goes down, it tends to stay down for some time.
Fine. Okay.
So I think our policy is usually to re-image patients that we're considering for transplant, or if we're retasting them, to do it 3 monthly.
Sure.
So we would usually check it every 3 months. I was just interested. So in this guy, we checked it monthly initially.
Thanks.
I see there's a question. Let me just see who it is. So someone has their hand raised. Can you see who? Sorry, I can't see.
Dr. Ide.
Hello, hello, can you hear me?
Hi. Yeah.
Yes.
Yeah, Chikwendo from Johannesburg. I'm good, yeah. I think this case, you know, it's the tumor is 3 cm, is resectable. The greatest challenge to surgery here is the portal hypertension. I'm thinking, I just wanted to know what your view is in if you are going the surgical route to do a TIPS before surgery. Will it make the surgery easier in terms of the portal hypertension?
So I think if you're doing TIPS can be done to make surgery easier, but that would often be surgery, not a liver resection. And my concern with doing a TIPS in this guy is that you could precipitate encephalopathy, and actually the ascites has resolved, and it's quite a small liver resection. So I don't think a TIPS is going to make an operation that much easier. So I don't think we're not planning to do a TIPS on him. You know, the only reason we'd be doing it would be to make the surgery easier, and I don't think it's going to make it that much easier, and it might even cause some complications. But but I think you could argue that it's a good point, and I think you could argue it both ways.
I would be a little bit worried, Mark, because if the patient is borderline for, remember the TIPS is sort of a total shunt. It's not a partial shunt. All the blood is going to be bypassing the liver. So the risk for this patient becoming encephalopathic is quite big. And then you go and you resect a little bit of liver as well. And I think that may just tip the patient into a problematic situation. So we usually would not do that. I mean, if you go according to the Milan criteria, people are very worried to operate on portal hypertension. But I mean, there are quite big series, especially from Japan, that show that you can quite safely do quite large liver resections if the liver function is maintained on patients with portal hypertension.
Yeah. Okay, if there's no other questions, I'm going to go on to the next case.
I have a question.
Oh, sorry. Yes.
Thank you.
Who's speaking? Sorry.
As well. I actually put my question in the chat room, but my question is that if the transplant is not available, for example, in my service, what other benefits that TACE might add for this patient?
So I've just put up a slide that shows what the benefits of transplant versus resection are. And the initial, so transplant in most series has a double, the perioperative mortality is twice the perioperative mortality for liver resection. Okay, obviously there's different types of liver resections, but you know it's generally got a higher perioperative mortality.
No,
the initial
my question is that
I'm gonna come to that. So the initial survival and initial disease-free survival is the same. After 5 years, patients who've had a transplant though have got a better disease-free survival. So that's the benefit of transplant. Why did we do a TACE? The reason we did a TACE in this patient was because we were testing the tumor biology. You know, we could have done a resection up front, but with an alpha-fetoprotein of 6,500, you're worried that in 3 or 4 months' time, there's going to be potentially tumor all over the liver, maybe extrahepatic disease. We did a TACE to treat the tumor that was there and see what happens with alpha-fetoprotein. It came right down, which suggests that we're dealing with just the one lesion, and it sort of gives us more of a mandate to take the patient to theater to do a liver resection and expose the patient to the risk of a liver resection. You know, this guy's not, he's got portal hypertension. He's a bit overweight. He's in his 60s. I think you want to subject someone to an operation if you're pretty sure it's likely to work. And that was one of the main reasons we did the TACE.
Thank you. That's a nice answer for the question. Thank you so much, Dr. Marc.
Okay. All right. I'm going to move on. So Wanga Mtumkulu is going to looked at this case. To a 62-year-old male, unlike the other patients, he's a very fit guy, excellent performance status, doesn't drink. He was diagnosed with hepatitis B many years ago, was seen at the liver clinic at Critisker, but was on a very, very rubbish medical aid that didn't pay for anything. So he was getting these accounts from the hospital that he couldn't afford, so he just defaulted follow-up. Anyway, then got onto medical aid and ended up having an ultrasound and some investigations done, and the ultrasound saw a mass in his liver. I'm going to just show some of his blood results. So he's got quite good liver function. His INR is 1.1, good renal function, albumin is fine. I'm just going to go through the MRI. Do you want to comment on what the main findings were?
You may be muted, Wanga.
You're muted.
Sorry. Yeah. Can you hear me now?
Yeah.
Okay. Yeah. So this is the arterial phase of MRI. So what we're seeing here is a hyper intense lesion with uptake of contrast in segment 4 and 3 of the liver.
Okay.
Yeah, it seems to be 3. Yeah.
Okay. Do you want to comment on anything else about the liver?
The liver there's a caudate lobe hypertrophy, and the liver itself does look, I mean, I can't really measure, but it does look a bit shrunken. It looks like it's of irregular border. I couldn't see any other lesions on the liver. I can't really appreciate any ascites on the MRI here. I'm not very good with that, I guess.
Yeah.
But yeah, that's.
I'm going to go to the portal venous phase. Oh, sorry,
Okay.
that's what's going on here now. Portal venous phase. Just what do you think about the right side of the liver?
There are some dilated ducts, but not significantly dilated, but there's some biliary duct dilatation. I can see also a lesion in segment 5 that looks to be.
Okay, we'll come back to this. Tell me, what do you think about the actual the large lesion that you mentioned? Its imaging characteristics on the portal venous phase.
So there's a washout in the portal venous phase. So this lesion looks more hypo-intense, comparable to the liver in the portal venous phase. And it had a hyper-intense quality in the arterial phase. So there was a higher contrast uptake with the washout in the portal venous phase.
Okay. Now, delayed phase. What is the delayed phase best for looking at? So this is it's a Primavera MRI.
So in the delayed phase, you're basically looking at that rim of if there's any capsule or the uptake in the capsule around the lesion.
So this scan would have been done at about 20 minutes. And you have your so the Primavera is taken up in the liver parenchyma. This is probably the best phase for looking for small lesions elsewhere, and it's a very good scan for looking for, like if it was colorectal mets, this is probably the best phase to look at for that. Then T2, what would you be looking for in the T2 phase? So what's in the differential diagnosis of a hypervascular lesion in the liver?
So the differentials is a cholangiocarcinoma. You're also looking at regenerative nodules. Also, sometimes you can get sort of metastatic lesions that are not primarily hepatocellular carcinoma. So
one of the things that's hypervascular in the liver is a hemangioma. This didn't meet the criteria for that, but in the T2 phase, it would be very bright. So that's why it's always useful to go look at the T2 phase. And then something that we often don't look at is the diffusion weighted imaging. So if you look at this, the lesion is bright, and that suggests that there's restricted diffusion, which is associated with malignancy. So putting that all together, what is the differential diagnosis?
Okay, so the working diagnosis here is that of HCC in the background of cirrhotic liver. The differentials would be things like regenerative nodules that we think it might be. Also, cholangiocarcinoma is something that one must put high up in the list. Those would be my differentials. It's
okay. So I think in a cirrhotic liver, we know that the probability of finding of there being a HCC is much higher. Hypervascular lesions are things like neuroendocrine tumors, hemangiomas, hepatic adenomas, fibrolamellar carcinoma, FNH. Those are things that come into it. So whenever you have a cirrhotic liver and there's an increased risk of HCC, we use the LIRAD staging system. So you should mention that. You've mentioned some of the things in the differential diagnosis, like a regenerative nodule, dysplastic nodule, and you know, in a cirrhotic liver and in the development of HCC, it often goes down that sort of pathway. And as you go from having a regenerative nodule to low-grade dysplastic nodule, high-grade dysplastic nodule, the degree of, or the amount of blood supply that comes from the hepatic artery increases and the portal venous supply decreases. Biopsy can be done. We are not a unit that likes to biopsy a lot. With modern day imaging, you can often make the diagnosis without a biopsy. It does have a risk of bleeding, especially if you're sticking it into something that's vascular, and it does have a risk of seeding things. Just once again showing how it becomes, you know, as it becomes more and more down the malignant pathway, you get more arterialization. So with the LIRAD system, if a LIRAD 5 lesion would be definitively HCC. And there's a whole thing about it, and you guys know about this, but I just want to make a couple of points. You cannot call a lesion LIRAD 5 in most instances. Well, you can't unless there's arterial phase hyperenhancement, which this lesion did have. And then the other things we look at are washout, capsule, and threshold growth. Okay, so I asked Professor Benningfield for his opinion on this, and this is what he said. So, you know, I think in an exam, you could say that there was arterial hyperenhancement, that there was washout, that you thought there was maybe a capsule, and that you think it's a LIRAD 5 lesion, but you could say that you would want a radiologist to confirm that. So, considering that this is a LIRAD 5 lesion, what are the treatment options in this guy? So he's got hepatitis B, he's got that scan that you saw, he's got an excellent performance status. And so the lesion measures 35 millimeters.
So this patient, he has got, first I want to know what is the Child-Pugh score of this patient, and also calculate his MELD score.
So his Child-Pugh score is A5 or maybe A6, and his MELD score is below 10.
Is below 10. All right. So the best thing then for him would be, ideally this patient, I'd like to get him through an MDT platform to review him and discuss his plan. And the surgical options for him would be ideally a resection. Because the tumor it's a solitary lesion. It's less than 5. I don't think he qualifies for a transplant because he's not a decompensated liver cirrhosis. I wouldn't put him for transplant. So I think a resection I would do more of an anatomic resection, take out that segment to a lesion. But I couldn't
the
really
problem here is what liver resection you're going to do. So you say non-anatomical, but it's I'm very concerned about, if you look there, okay. So I think that's just it's very closely related to the left hepatic vein, and I struggle to see how you're going to do that and maintain the blood supply to segments 2 and 3. And the thing I was trying to point out to you earlier was that the right side of the liver is quite atrophic, and I worry that if we resect this, there's not going to be sufficient liver volume, especially in someone who's got cirrhosis. You know, in a cirrhotic patient who's Child-Pugh A, you need to leave them with 50% of their liver volume. And you could say, okay, well, you're going to try to do a little wedge resection, but if you get it wrong and you devascularize this part of the liver, then the patient's going to die. So I don't think resection is an option. What do you think about ablation in this guy? So it's 35 millimeters.
It is sort of borderline, but I think one can do then some ablative, can do a TACE, because especially if it's very close to these vascular structures, as you've already alluded, to try make the tumor smaller, and so that one can achieve a clear margin resection, and that would help us to achieve adequate liver resection without compromising him for his future remnant liver. But what also one can do is also to do a portal vein embolization as well to try aid that future remnant.
Yeah, I don't think you're going to get massive hypertrophy in a part of the liver that's already got smaller. So I think here, I think ablation is going to be difficult because of the size and because of the proximity to the vessels. I actually think transplant's a good option for this guy, even though he's got well-preserved liver function. You know, we often, the HCC patients who get transplanted often are the ones with good liver function. You're not transplanting him because he's got cirrhosis, you're transplanting him because of HCC, and we know that he's fit, so he's got a good chance of getting through the transplant, and we know that this has got the best disease-free survival at 5 years. So that would be the argument. The one concern was that his hepatitis B had not been managed, so we started him on treatment for that, and because of that, and also because of the delay that there is on the transplant list and getting someone listed, we did TACE him. It didn't get much smaller, and his viral load is now undetectable. So I'm not going to go into all the issues about transplanting patients with hepatitis B, but that was the way that we felt that we're going to go. All right, I think that's the end of that case. Are there any questions or any comments? Someone, if you have any comments, just raise your hand or. Okay.
Marc?
Yes.
Yes, Tabo, Pretoria.
Right.
Yes, I was just wondering, for both cases, when would you fit in, like, including medical therapy with the TACE?
The
newer one, bevacizumab. I know the first one, bevacizumab, because of the VGF, so you have to treat the varices for bleeding. But I'm just wondering, where do we fit in the medical therapy?
So the medical therapies are things like sorafenib and your tyrosine kinase inhibitors, and now there's these new studies that have shown these biological bevacizumab, and as I can't say the other one's name, but those drugs are usually used. They're not used in patients who can be offered curative therapies generally. So if you were just going to TACE a patient and offer them just TACE, or if you weren't going to TACE them, but they weren't a candidate for any other therapy, that's when you could consider those treatments. Now, my understanding is sorafenib is generally available in South Africa, and bevacizumab is generally available, but some of those newer agents are not. So I think that's going to become an option, but I think those medical therapies are more for patients with more advanced disease where you can't offer them one of the curative treatment options. There's a debate about whether you should offer medical therapy after a TACE. So if you're doing TACE for just palliative intent, should you give medical therapy after the TACE? TACE does block off the blood supply to the tumor. So, and now you're giving a systemic therapy. I think it does make sense if there's quite diffuse tumor and the patient's still got a good performance status. I don't know if that answers your question. So with these two patients, we're still trying to manage them with curative intent. So we wouldn't start them on medical therapy yet.
Okay, thank you.
Any other questions? Okay, let's move on. Okay, so the next patient, quite a long story. So 56-year-old, he was born in Taiwan, but he's lived in South Africa for most of his life. He was diagnosed with hepatitis B in the late 90s. At that stage, there weren't very good treatment options available for hepatitis B. He was lost to follow-up when he returned to Taiwan. His comorbidities include ulcerative colitis, which is quite stable on medical therapy. He still has his whole colon and rectum in situ. He's also diabetic on insulin, but he has a fairly good performance status. He presented to hospital now complaining of right-sided abdominal pain. He had a gastroscopy, didn't show evidence of portal hypertension. Colonoscopy was really not too impressive despite the ulcerative colitis. And there was nothing else much on the examination. If you look, his liver function is excellent. His tumor markers, interestingly, his chromogranin was slightly elevated. And because he wasn't on treatment for hepatitis B, his viral load was high. Sanju, what do you think of the imaging? You muted.
Can you hear me, Mark?
Yeah.
The MRI scan, the actual cuts, 3 millimeters in size. What I can see is quite obviously that it's got some hyper enhancing lesions in segments 6, 7, and I would assume 8. I think 5 is free on that side. I can only comment on his arteries really at this stage. I mean, he's got standard configuration of a celiac trunk. He's got an SMA with no replaced right. There's also, I can clearly see his hepatic veins as well. Can't really comment on his portal vein at this stage. And I cannot see any further lesions on the left side of his liver. And his gallbladder, from what I can see in this phase, looks fairly normal. And I cannot see any huge ducts.
Okay, so I've shown you the arterial phase, portovenous phase. So it's difficult to say if there's, I suppose there are areas of this tumor that are hypervascular.
Yeah.
Let's always remember that very big HCCs often don't follow the typical, pattern of portovenous washout and everything. But I mean, I do think that there is washout there compared to it's certainly darker than the surrounding liver. What is this? This is the 20-minute delay.
Yeah. You can definitely see now that there's washout.
Yeah. Okay. And then, sorry, I didn't show the T2 phase, but it wasn't bright in the T2 phase, so it's not a hemangioma. And then there is restricted diffusion.
Yeah.
So this is not the most straightforward case because there's a couple of confounding factors. What is the differential diagnosis?
Yeah. So
what further investigations do you feel are needed?
Sure.
Yeah, let's start off with that.
So, I mean, given the history of this gentleman, he's of Asian descent, assumed from Taiwan, an area where hepatitis B is endemic. I think at the top of my list would be an HCC. The other issues that, given his history of ulcerative colitis, one must
also help that this is a TAT on HCC.
Yes. The other issues, given the fact that he's got ulcerative colitis, one must be mindful of the fact that these patients can end up having PSC, PBC. A significant number of them will have MAFLD. And there's also the issue of drug toxicity associated with these patients, since they are on long-standing therapy for most of the time. The third issue here is, as far as my differential diagnosis is concerned, I would say, and the third issue is obviously the hepatitis B. And there are, as you say, further confounders here. The one issue is certainly the fact that he's got ulcerative colitis. You would expect him to be on some form of immunosuppressive therapy, whether this would be prednisone, interferon.
He's just on, my understanding is he's just on Asacol, and it's quite well controlled on that.
Yeah. So even that there's a small chance of affecting carcinogenesis in patients with HCC. So that's something we must bear in mind. The other option for him is, I said, an HCC. The other option obviously is a is a cholangiocarcinoma, given the fact that he is at risk of PSC, PBC. The third one is a metastatic lesion, although unlikely. The fourth one, given is high chromogranin A, is a neuroendocrine tumor. Looking at the scan, it does look like this is most likely an HCC.
I agree with you. So we'll come back to that, the differential diagnosis. Just quickly, and luckily this is the surgical for the surgical fellow, so we don't have to go into hepatitis B management in too much detail.
Sure.
But how would you manage his hepatitis B?
Marc, as far as I looked, he's got a log of 0.6, I think. As far as I remember with the values, that is not totally suppressed.
No, it's definitely not. It's very high. So
it's very high. So one must consider antiviral agents, but given the fact that he has liver cancer now, I think the appropriate combination is, I think, interferon and a nucleoside antagonist and an NA.
So we don't usually give interferon anymore. So with this guy, you really have two options. And he only needs single agent therapy. He's never been on treatment before. You need to make sure that he doesn't have HIV. And you can either start him on lamivudine or tenofovir. And in this case, I would start him on lamivudine. The reason is that it's got a very good side effect profile, and it brings down the hepatitis B viral load very quickly, which is probably what we want. And if you're going to be needing surgery or some form of treatment, or you've got a complication like a cancer, then the hepatitis B needs to be managed. So I put him on lamivudine. We started treating the Hep B ourselves, and then getting the liver guys involved a little bit later, because it for some reason irritates them. But I mean, basically, I would start this guy on lamivudine.
Marc, can I ask you what? Sorry, he was tested for Hep C, eh? He is not Hep B, Hep C.
No, he doesn't have Hep C.
Hep C negative. Okay.
Yeah. And he's HIV negative. So obviously, if he's got HIV, then he needs to be on triple therapy and something that contains either lamivudine or tenofovir. Okay. All right. So you start on medical therapy. So I think the most likely thing is an HCC. I don't think you can say definitively from this imaging that it is an HCC. There's no evidence that he has PSC, but if he did, he would be at increased risk of probably more like a hilar cholangio than a peripheral cholangiocarcinoma. Patients who have cirrhosis are actually at increased risk of getting intrahepatic cholangiocarcinoma. So that's always on the cards. I don't think this looks like that. The neuroendocrine tumor, the thing that, it's a hypervascular tumor, and he's got a slightly high chromogranin A. So you can't completely rule that out. We did a CT scan. We didn't do a Dotanox scan or anything like that, but we did a CT scan, and there was no evidence of a primary anywhere. Okay. So considering all of that, what would you do next? So there's a couple of options. What are the options?
So look, I think, given the context of the patient, I think this is an HCC. I think looking at the values you've given me and his performance status, he's obviously, I looked at his values as a Child-Pugh A5, and is definitely a low MELD. I would say that this patient would benefit from a liver resection at this stage. He's got.
So why not biopsy the lesion? Because you could make an argument for it.
So I'll just tell you, when I was in Toronto, the standard of care was a biopsy with these patients. They would get a biopsy. When I came here, it was a bit different. So I think as an institutional practice, my understanding is that we don't often like sticking needles in there. But I can see now a biopsy was done.
No, but it wasn't done. So now I think this is important, and I know you went to Toronto, and I know that they do lots of biopsies. There's a lot of centers that are very anti-biopsy. Okay. So for instance, I know in Nebraska, they're very anti doing biopsies, and sometimes they will not even transplant someone if they've had a biopsy. So I think it is a bit unit specific, but I think as a whole, you shouldn't do a biopsy unless it's going to change your management. Okay. So we didn't biopsy the tumor. We biopsied the other side of the liver because if you look at that liver, it doesn't look cirrhotic.
Yeah.
But I was quite interested to know if he had cirrhosis, and he does actually have cirrhosis. So what that pushed us to do is we then did a portal vein embolization because the volume on that side was about 48%. So we then went on to do a portal vein embolization, followed by liver resection. So this biopsy did change our management because if there was no fibrosis, we probably wouldn't have done the portal vein embolization. Okay. All right. So yeah. If you biopsied it and it was an HCC, why not transplant it? What would they do in Toronto?
So it really depends. I mean, I think we were having this argument the other day in the corridor. It really depends. I think in the face of cirrhosis, if you know that the patient has cirrhosis, then you would obviously consider a head-to-head comparison. So what does Milan criteria say? What does UCSF say? And what does extended Toronto criteria say? Extended Toronto criteria is actually for patients who have liver cirrhosis. So there's no limit in the number of lesions. However, a biopsy should be done, as I was telling you, and they should be well differentiated at worst. In a worst case scenario, there should be no extrahepatic disease and they should have no vascular involvement. And the data at 5 years with the extended Toronto criteria is a 68% survival rate compared to Milan, which would put you at 70%. And there's no difference in the retrospective study they did. Having said that, that is still controlled by the total tumor volume. So there's still a limit set. And interesting they didn't put it there. And the total tumor volume should not be more than 115 centimeter cube. So there is a cap set there.
So yeah. I think I don't want to get into a discussion about all the different. So I think the point about transplant criteria generally is that every unit, and that's why there's so many different ones. And I think if you get asked this in an exam, you bring up the Metro ticket system and how, you got to decide what's appropriate for your unit and what survival you want. I think the Toronto ones are interesting in the fact that it's one of the few criteria where it relies on a biopsy and saying that it's low grade. Interestingly, because I was reading an article about it, so the survival is quite good, as you said, but it doesn't take into account alpha-fetoprotein. And if you look at the patients who got transplanted with an alpha-fetoprotein above 500, they did very badly. Mm-hmm. So my feeling is we use the UCSF criteria, and I don't feel like we need to stick to it absolutely. I think if you have a patient who's a bit out of those criteria, who you can demonstrate has good tumor biology, that you can go beyond the criteria. And I think, I think sometimes we get too stuck on the criteria, but I do think alpha-fetoprotein is also important, and that's something that's left out of a lot of the criteria. And I must say, maybe if we are considering transplanting people who are outside of criteria, maybe we should also do a biopsy to see that it's not high grade. It's something that I haven't thought about before. Okay, now we decided to resect this guy without a biopsy. And our reasoning was that if it was a neuroendocrine tumor or a neuroendocrine tumor metastases or an intrahepatic cholangiocarcinoma or an HCC, it was resectable, and resection is the treatment of choice for all of those. So we resected it, and it was a multifocal HCC. The largest nodule was about 60 millimeters. They say 58, but it was actually 60. There was no vascular invasion, and there was an R1 resection. So we also know in liver surgery, they often call an R1 resection, and there's a higher recurrence rate if you have that, but it's not an absolute that you will have a recurrence, because sometimes the tumor fractures or whatever as you're resecting it. So what would you do after? How would you manage this guy after the resection now?
I'm just looking at the
non-hepatitis B treatment.
Yep. I mean, I think my standard answer is that I would still manage him within the realms of a multidisciplinary team. He should see a hepatologist. He should be seeing his gastroenterologist for his UC. He should be in an adequate treatment for both of them. And I would make sure that his viral load is suppressed sufficiently. From a surgical point of view, I would want to have him on a tumor surveillance program. I think given the fact that they mention an R1 resection here, I would have a shorter interval in seeing him in the clinic over the first year, probably with imaging and an alpha fetoprotein level to see where he's at.
Okay. So what we did is,
Yep.
I mean, he had regular follow-up MRIs, and 6 months after surgery, I'm just going to show you. So this is the liver remnant, and the liver remnant, the liver remnant looks fine. So you can see we left segment 4, we left segment 2, 3. There's no recurrence there, but there were some enlarged nodes, sort of periportal and around the head of the pancreas.
Yeah.
But at the time that the scan was done, which was actually in November last year, he was having a flare of ulcerative colitis. So what would you do?
Where's this lymph node, Mark? Sorry, I can't really see on the dynamic.
There's a couple, and they're very close to they're sort of peripancreatic around the head.
I would, yeah, I'm thinking EUS and a biopsy would be an option in that area.
Okay, so we did that, and it showed metastatic hepatocellular carcinoma.
Okay, so well, obviously now this is extrahepatic disease. You know, if you look at the criteria, you now should get some form of biochemical or biologics at this stage. So either sorafenib or, I can't say the words, one of the MABs. So either the best.
So there's the two MABs.
Or the aciciltuzumab. So it's one of the two criteria.
So I was reading a little bit about this last night, and it's probably one of the areas that you guys need to, well, it is one of the areas that you guys need to know about, because it's quite topical at the moment. So there's a thing called the IM Brave trial that showed that bevacizumab and the other MAB are it was more effective than sorafenib. So this is the situation where you would use those drugs, and you know, you're using it with palliative intent to try and improve survival. Another thing that I didn't know until my reading yesterday was that sorafenib is much more effective in patients who have cirrhosis due to hepatitis C. And I think, you know, we really went off using sorafenib. And if you think of our etiologies of liver disease in this country, that's probably one of the reasons, is that sorafenib, you know, we don't have lots of HCCs in patients with hep C. So maybe these newer drugs will be more beneficial. But in that study that looked at bevacizumab and the other one, they specifically excluded patients with autoimmune hepatitis and patients with hepatitis B and hepatitis C, because they were worried of causing like an upsurge in the virus. So those are just things to take into account. But you know, it's always easy to say in hindsight. I mean, I think we made the right decision to resect this guy. And you know, I think in our context, if you can resect, it's generally better because of the availability of organs. But you know, if you look at this guy, if he'd had a transplant, he would have now also been on immunosuppression with extrahepatic disease. So that's something that we don't always consider. You know, this guy's now, at least he's not on immunosuppression, and he never had bad liver function. All right, I don't know if there's any questions or comments about that case. That's the final case. So we're coming to the end. If there's any questions.
Mark, but this is one of the cases where the Toronto criteria fails, right? So he's got well differentiated histology. By definition, he should survive about 5 years, but he's the one who gets a met 6 months down the line and doesn't make it. So
that's why I chose this case.
Yeah.
Hello. May I ask a question? Yeah.
Yes.
So Chikwendo again. So we will in Johannesburg, a case like this, if we're planning to resect, we will biopsy the liver that will leave behind to assess for the fibrosis.
Yeah.
I just wanted to find out what's your opinion, because there are imaging modalities that are coming out to assess that degree of fibrosis, like the mebrofenin and the Fibrous Scan. And
So,
what's your experience with them, and would you recommend them in place
it's a very
of
good,
biopsy?
it's a very good question. And Fibrous Scan was developed to assess the degree of fibrosis in patients with viral hepatitis. The problem is when you have a right-sided tumor, when you do a Fibrous Scan, it assesses the right side of the liver usually. So it's difficult to use a Fibrous Scan when you have a big tumor like that. So that's the problem. I think if you had a tumor on the other side of the liver and it wasn't that big, it would be quite a good option, and it could save the person having a liver biopsy. So I think we don't always do biopsies of the liver remnant. And I think, like I said, you got to do it if you think it will change your management. So in this case, we did do a portal vein embolization. But yeah, there are other ways of assessing the degree of fibrosis. You're correct.
Thank you.
Okay, Marc, I think that's about time for us to conclude. Are there any other comments from anybody? So as we said initially, this is a session that we want to develop optimal for the need of our fellows. Any comments on the format? You're also welcome just to put them in the chat afterwards. So anybody that wants to say something, is there something that should be changed? Too many cases, quicker cases? It doesn't look like it. So we will then next week do the second teaching session. That will be Adam Bootle, and I believe the topic is going to be the management of advanced rectal cancer. And then just finally to thank Marc and the fellows for a very nice session. As I've mentioned earlier, we do this in cooperation with the ECHO program at the University of New Mexico, and we usually have the ECHO team from India with us as well. Feedback, please, on the chat if there's anything more that you want to leave. Then the recordings will be available on the Gastro Foundation website. And yeah, thanks for attending. Enjoy the rest of your day.
Cheers. Bye. Thanks.
Thank you.